Hello, everyone, and thank you for joining. We'll be starting in just a few minutes. Good afternoon, everyone. On behalf of the Hepatitis B to Connect program, I want to thank you for joining today's webinar. My name is Sierra Palecchio, and I am the program coordinator of the Hepatitis Delta Connect program at the Hep B Foundation. And we're very excited to present today's session on diagnosing hepatitis delta in the U.S. with expert speakers Dr. Gish and Dr. Hillyard. Before we get started, I'd like to review a few housekeeping items and let you know how you can participate in today's webinar. Please note that all attendees are in listen-only mode and will be muted during the presentations. There is also a phone-in option, and the call-in numbers are on the screen. You may submit your questions in writing during the presentation by typing them in the question box on your GoToWebinar control panel. We will be reviewing them as they come in and holding a Q&A session after the presentations conclude. And finally, today's webinar is being recorded, and you will receive an email with a link to view a recording of today's presentation after the webinar. And just a disclosure that Dr. Robert Gish is a medical consultant for Eiger Biopharmaceuticals. And now I'd like to introduce our speaker today, Dr. Robert Gish, the Hepatitis B Foundation's Medical Director, and also Dr. David Hillyard, Medical Director of Molecular and Infectious Diseases at ARUP Laboratories. And with that, I'll turn it over to Dr. Gish to begin the presentation.
Thank you, Sierra, very much. I also want to thank the Hepatitis B Foundation. And David, thank you for joining us today, because we've made a major leap forward in the U.S. by having advanced diagnostic testing available for delta hepatitis. And I'll switch back and forth between HDV and delta hepatitis as I move through this presentation. And let me just see if I can get the slides to go forward. There we go. And first off is, how many delta patients are there worldwide? How many people infected? We think that number is 15 to 20 million. Hepatitis delta is the most severe form of chronic viral hepatitis, and if you don't test, you won't find it. And I give lots of talks on B and C and ask people, how many cases of delta have you seen? Most audiences, no hands go up. Then I ask, how many of you have tested for delta? Again, no hands go up. So if you don't test, you won't find this disease. The clinical manifestations differs, and a lot of this has to do with, is it acute, is it chronic, rapidly progressive, slowly progressive? It's quite dynamic because both the hepatitis B and D contribute to disease progression, and of course you need to assess both viruses, their activity, their viral levels. Who are the risk groups? Now, you could take a simple approach and just say every patient who's surface antigen positive should have Delta testing. I think most of us want to be a little intellectual about this, but the problem with being overly intellectual, if you put up too many barriers, you don't end up testing anyone because you don't think about it or you're not sure of the history, and you opt not to test. So if you're thinking Delta, order the Delta antibody, not Delta antigen, Delta antibody. That is currently the standard of care, and David will go into that Delta antibody testing as well as the confirmatory Delta RNA testing in a little bit. We're both essential as part of this. And I have some very simple rules about who to test. One, has there been any high-risk sexual behavior? Any IV drug use? This, again, surface antigen positive patient. And then, are they an immigrant population? Low risk is the Asian patients coming into the US, but you'll see data a little bit later that these patients from Asia can have Delta, and it tends to be in pockets meaning risk behavior pockets. And we'll get into that in a little bit more detail. Let's say you have a patient with advanced fibrosis or cirrhosis with hepatitis B. They should all have Delta testing done. And if you have somebody who's suppressed on that hepatitis B drug of your choice, you would assess their ALT. If the ALT remains elevated, you're going to think Delta, you're going to think NASH, and you're going to think alcohol, because only 2/3 of patients on one of the nukes, this is TDF, TAF, or entecavir, have normalization of their ALT. So Delta testing would be important there. Genotyping, we're not going to go into great detail. There's a large slide deck that David, I, and Sierra put together, which will be posted on the website, and that will have about 100 slides in it, and that has genotype information. But I'm not going to go into that in detail today because we clinically don't use genotype in our practice. All right, virology. Delta hepatitis is a viroid. It's a small RNA virus that is incomplete. It requires surface antigen for packaging, and to package, that of course means to be infectious, to then transmit disease. So as far as we know, no surface antigen, no Delta packaging, no Delta transmission. Delta may still be able to live in the liver, and there's actually a couple of interesting papers recently that came out that implicated Delta virus in a sequestered form in salivary glands that was associated with Sjogren's disease. So Delta might affect other organs other than the liver, but that again is up for discussion and confirmation. But this is the bottom line. If you don't have surface antigen, you're not going to package Delta. You won't have Delta infection in terms of blood infection or transmission risk. So let's keep that in mind. There's a lot more about the Delta virology that we could go into during a future seminar if we do a gap analysis and see if there's a demand for that. It's quite complex and interesting. So, Epi, let's see if I can go back. There he is. So there's a couple of maps in this deck. I chose this one. There's another Delta map that's quite interesting, but I like this one because it actually gets down almost to a country or regional level. So you can see up in the Central Asia, Mongolia, there's quite a high prevalence. Mongolia has probably got the highest prevalence. Look in South America, Upper Amazonia and what's called the Orinoco River Valley, high prevalence. There's a number of countries, including I think the Central African Republic, and I think the other one's Kenya. But look here, we've got Egypt, we have Somalia, we have the Ethiopia. They're all also, and you're thinking basically Horn of Africa. You're thinking Middle East. You're thinking into India. There's a couple of inaccuracies on this map because Pakistan says no data. We have actually very good data on Pakistan now. So Mongolia and Pakistan are going to be two of the highest prevalence rates, and then we have Eastern Europe, and I think that is Romania. That's the hot spot in Europe, and I think we have another map a little bit later that we're going to talk about. So immigrants, yes. Immigrants from these special areas, super high yes to test for Delta antibody. These are the AASLD guidelines, and it says here, test for co-infection with hepatitis C, Delta, and HIV in those at risk. It doesn't even say at high risk, it just says at risk. So basically stating that there's a low threshold to check. And of course, if you have hepatitis B, hepatitis C, and HIV should basically be automatic. Delta should be very close to automatic, and it's in these guidelines. It just says, look systematically for Delta infection. So the basic take-home message there, low threshold for testing. Here's prevalence of Delta hepatitis in the Asia-Pacific region. So you can see that we've got Korea, even though it's quite low, but Iran, where I was just a couple of weeks ago, has high prevalence. That's 8% of the hepatitis B population, and the B population in Iran ranges from 1 to 4%. So 8% of 1 to 4% gives you your denominator in a country. I think it has about 40 million people. India depends on location, but 10 to 15%. Pakistan's up to 45%. And Turkey, there's a gradient from northwest, where it's in the 2 to 3% region. Izmir's on, I think, on the coast of the Mediterranean. To the very southeast region, which is the Kurdish region that is really on a non-geographic map, would be Kurdistan. And of course, the Kurdistans go into northern Iraq, so in Iraq, northern Iraq, will be Delta hepatitis as well. Here's the blow-up on the Delta in Africa. We just mentioned a couple countries here, which I think is Kenya and Central African Republic, so these are locations you just got to think. And my threshold is, if I have an African patient in front of me, surface antigen positive, that's got active liver disease, I just check, because there's a lot of countries where data is missing. White here means we have no data. And there's a number of genotypes in Africa. Genotype 1 is the most common in the US and in Europe, but look at all the other genotypes up to genotype 8. So I think this is quite interesting. But unlike C or B, we're not genotyping Delta at this time in clinical practice. A little bit bigger map here about Europe. You can see Moldova, Romania, Albania, Turkey is hot spots that are there also. And basically my rule is Eastern Europe, anybody from Eastern Europe would get Delta testing if they're surface antigen positive, Delta antibody testing. So interesting publication, 2000, up to 2012, 1991, 71,000 individuals had specimens, and then of those, 73% had Delta testing. They said the overall prevalence of Delta in the United States is 0.02%, or 10 per 52,000 in the study, mean age 52. But if you take a look at these numbers, it's probably going to back up pretty closely our estimate in the U.S. of 70 to 90,000 individuals are Delta positive today. This gives you a little bit more demographics on the Delta positive patients. So if you look in the right column, a little bit older age, in their 50s, a little bit more men than women. Quite diverse here, multiracial, other races, 30%, and 10% were Mexican American, and 50% were non-Hispanic Black. So you're really going to be thinking about Delta testing in a variety of different ethnic groups. And there were a significant number of patients who are C, so now it's called tri-infection, C, B, and Delta. Injection drug use in this specific study was low, but that may have been that they missed that diagnosis. And there was MSM as one of the risk factors. Again, this is in Hepatology 2016 US data. So there is some data that prevalence is increasing, but is this true increase or better surveillance? But the numbers are high, and in a disease that has a 70% risk of cirrhosis, liver failure, liver transplant, or death, this is much higher than B or C. This is a disease you want to test for, and of course there's a number of new drugs that are in development for treatment. You want to warn the patient about their risk, doing heightened surveillance for, say, varices, liver failure, liver cancer. And there's some other data from Baltimore. There was a decline in prevalence in IV drug users up to 2006, maybe because of harm reduction. Veterans were tested. I think it's David Goldberg who did this one. It was 4%, 3 to 4%. And Haynes, we just talked about a few moments ago. The study that I was first author on from San Francisco had an 8% delta rate in patients from Northern California. The study site was San Francisco, but the patients were basically from Fresno to Oregon, Western Nevada, and obviously an immigrant population that was there. So a little bit more. This is Kushner, 2015. This is about 3.5% of S antigen positive were tested were anti-delta positive. Men more than women. Interestingly, Asian ethnicity. So of course we've got different regions of Asia that are higher risk. So Burma, Myanmar, that area, there's more IV drug use, higher risk of delta exposure from that reason. Core antibody IgM positive, a little bit higher, and IgM in most cases indicates acute disease, but in people with very active hepatitis B, the core IgM can remain positive or flip back or revert to being positive. Interestingly, E antigen positivity a little bit higher. C was a little higher numerically, was statistically significant, but probably numerically minimal. HIV higher as well. A much higher peak ALT in these patients, much more active liver disease by ALT assessment. And DNA levels were suppressed because hepatitis delta hijacks or manages the hepatitis B replication machinery. And most patients have low hepatitis B DNA. We used to say undetectable, but that's when we were using less sensitive tests. So we're just going to use the word low at this time. More diagnosis is taking place in the US. If you look at this inflection point about 2009, we are increasing every year, year over year, the number of patients who are excuse me, who are being diagnosed. This just means more testing is being done because individuals like yourself are active in practice and now thinking about delta. This delta has been there, it just hasn't been diagnosed. So if you add up all of these numbers and you add them up year over year, you're getting up in the 40 to 50,000 range of delta patients just by looking at this survey. And this was a poster at DDW this last year in May of 2017. So chronic hepatitis B, this is percent of patients with delta. That's the green line. We've been giving you numbers of 3%, 4%, 8%. But this most recent survey that Eduardo Bartens and Jeff Glenn showed is that number may be higher. It's heading up towards 12%. Now this is newly diagnosed patients with chronic hepatitis B, though it's possible that there's some inherent bias that you're picking up more acute. Acute was maybe have a higher risk of being B/D co-infected. Those are things to think about, that we've probably been missing a lot of delta infection over the last years, and by advanced testing we're going to diagnose more patients and then start offering them surveillance, education, and eventually more effective therapies. What about Vietnam? This is kind of interesting. Prevalence of hepatitis delta genomes in surface antigen positive patients. And on the left, acute hepatitis B, 43% were delta positive. In their patients with cirrhosis, 12%, chronic hepatitis B, 11%. These numbers are biased because this came out of a study in Hanoi in a IV drug use population. So I'm not going to say you have a large Vietnamese patient practice, you need to check everybody for delta. That's not the message here. But there is a message that anybody who's from Vietnam with any risk behavior who's got hepatitis B should be checked for delta, and delta antibody is your screening test of choice. So we have co-infection and super infection, right? So co-infection means you're getting delta and B at the same time. It's usually sick, that's severe. these patients have a high chance of clearing Delta and hepatitis B. Hepatitis B is not curable. So once you've got B, you've got a little bit left in your body the rest of your life. But we call that a functional cure, which is one of my favorite oxymorons that's out there. And Delta is an RNA virus. RNA viruses are almost never chronic. There are exceptions, of course, with HIV and HTLV1 and 2. There's probably a few other, but most RNA viruses either hurt the host or are subclinical and are self-cured through an immune response of some type. Hepatitis A and E would be examples, although, of course, hepatitis E is occasionally chronic in suppressed individuals, so immune-suppressed individuals. So Delta co-infection, but superinfection is when you've got B, you've had B for a while, and then you do something high risk or you have a high risk setting, then you can get a severe hepatitis, and sadly, you don't clear the Delta and you don't clear the hepatitis B, so you have chronic Delta in 90% of these patients. Now, things have been interesting. Over time, let's say we're going back to 1998 or 1980. It looks like the numbers are a little bit off on the bottom. That usually had a young patient, locally acquired IV drug use, but now in 2010, it's older patients, immigrants, and then again, special risk groups as well. Back 30, 40 years ago, you had severe acute and relatively severe chronic disease. And then there was a period where we said, oh, Delta's not that bad. Well, just so happened most of the people with bad disease died. The people who didn't have bad disease lived. A little bit biased there in terms of your survey. But then we really figured out that, oh, those people with mild chronic disease aren't going to die in 2 years. But within 20 years, they're at very high risk of cirrhosis or cancer, death, or transplant. So this is a serious disease, and this justifies testing almost everybody who's surface antigen positive. If you want to make it simple, go down that pathway. You want to do just low-level testing, then you're going to be checking maybe 50 to 70% of your B patients for Delta. All right, we talked about Delta requiring surface antigen for packaging, being infectious, being extrahepatic. There is intrafamilial transmission, vertical, sexual, sharp devices, folk remedies, scarifications, percutaneous exposures. Medical treatments, blood transfusions outside the U.S. There are still some countries that do a very poor job of even screening for simple things like hepatitis B, hepatitis C, syphilis, other things that are there. And of course, you've got risk with any sharp devices as well, surgery in different countries. Special risk groups, IV drug use, very special, HIV positive, high-risk sexual behavior. Hemophiliacs, yes, historically, but that's, I think, a very minor part of the population now at risk. And dialysis, well, prevalence is high, but these are not high-risk individuals for Delta. So these are basically discussion points for this slide. And if you have hepatitis B vaccine, you prevent B infection, and thereby you prevent Delta infection. This is a profile in Delta positive patients, E antigen positive patients. What's the DNA level? So in the white box is DNA negative. The vertical right running hash tags, which is almost 50%, is less than 2,000. Then in the horizontal lines, you've got 2,000 to 200,000, which is mid-range, and you can see above 200,000 makes up probably 20% of patients. So Delta hijacks B machinery, suppresses B DNA. Most patients have low HBV DNA, but they got Delta and they've got active liver disease, they've got a measurable DNA. Those patients should be treated with a nuke, as well as trying to decide on their treating of their Delta, whether you're going to go down that pathway or not. If that makes sense to everybody. And what I'm doing right now is trying to get my screen back up. Something just happened. Here we go. All right. And I guess I can go slide forward. And let's go slide back. Seems like it's jumping just a little bit. I got twitchy fingers. Okay, liver disease progression. So in the left box, there's this survival issue, and 100 months is going out. So 12 months, that's basically 8 years.
half the patients have died of cancer or decompensated liver disease in 8 years or less. So that sounds very, very significant. This was a 28-year prospective study, and 25% of the cirrhotic patients developed liver cancer. 60% developed liver failure during that time. There was a study in Taiwan, because there was a big Delta outbreak in Taiwan a number of years ago in the sex industry, and those patients had an 85% mortality rate in 15 years. I use the number 70% to get patients' attention. And of course, you have more rapid progression of liver disease when you're co-infected, earlier liver failure, higher risk of liver failure, more portal hypertension, and the complications of cirrhosis. Here's a very important issue. Hepatitis C RNA levels don't correlate with liver disease. In hepatitis B, the DNA level is a dominant issue for how bad the liver disease is. Chronic hepatitis D RNA levels do not correlate with disease activity. The only way you get them to low risk for progression is to get everybody delta RNA negative. But if you can just reset the RNA value to something that's down 2 or 3 logs across a population, there may be a benefit. But the study says an individual basis does not have a direct correlate with disease activity. What do we mean by disease activity? We're talking about risk of progression to cirrhosis or cancer. All right. So when we're going to treat hepatitis D, we of course want to cure the D, but that's going to be difficult. We can eradicate B, get to a functional cure, which is S antigen clearance. And if you get S antigen clearance, you're going to have highly likely control of your delta infection. But basically the take-home message here is that nukes have no effect on delta RNA replication levels. We would like to normalize ALT because ALT in hepatitis D, like B, correlates very well with liver histology. And because this is a paper that just came out in Science this week, I was one of the co-authors on, showing that hepatitis B integrates into the genome and is making S antigen off immigrants. And that S antigen is enough for delta to piggyback on, which is very, very interesting. Learned that recently. But this is a little bit of bad news, but when you're designing a clinical trial, really your best endpoint is to reset the RNA, normalize the ALT, not in practice, but in a research study, we'll be getting liver biopsies on those patients and try to correlate and pull these things together. Currently, I think there is a good correlation. So you can reset the RNA level, even though a baseline RNA level may not correlate with the risk of disease. I think a lower RNA level will decrease the risk of disease, provided that the ALT is lower or normal. So what's the word on interferon? Pegylated interferon, the basic rule is you treat for 1 year and you follow for 5 years. The cure rate's less than 20%. It's probably as low as 15%. There is a study from Turkey where patients were treated with interferon as long as 5 years and then had a follow-up interval looking for SVR, and that was very close to 40%. But how many of your patients are going to be willing to take pegylated interferon, maybe even at 90 mics per week, for 5 years? Not too many. So that's why the delta world is changing rapidly. There's new drugs being looked at for delta infection. There's one from Eiger that's called a premolation inhibitor. There's Miclirdex, which is being developed in Germany and Russia with Stefan Urban. That looks as an entry inhibitor, but that also appears to be blocking delta RNA and maybe curing that. And then there's another company called Replicor, which has what are called MAPs, these polymers, that also look to be suppressing delta. And at some point, we'll have more information on whether it's actually curing the delta. But to cure delta, you've got to have long-term data, because the relapse rate that we learned from studies like Heiner-Wiedemeyer's study called the HIDIT, H-I-D-I-T, showed about half the patients who were, quote, cured relapsed within 1 to 3 years as you followed them long-term. So genotype 1 is the most common, has a lower response rate, lower viral load, better response, and if you're negative on treatment, that's always nice, higher chance of having an SVR. And then, of course, our favorite test in the hepatitis B world these days is quantitative hepatitis B surface antigen. If you have a lower quantitative hepatitis B surface antigen, you have a higher chance of curing delta. But 15 to 20% is the general rule right now with interferon-based therapy, unless you go a lot longer. Now, this is the HIDIT study that was done with tenofovir plus pegylated interferon. And this was basically, I'm showing you this slide, that the addition of tenofovir, this is TDF, not TAF, TDF to pegylated interferon alpha 2A did not improve the chance of clearing this. Now, in this study, they had 23 to 30% of patients who had a, quote, SVR, which is 6 months after stopping treatment. But long-term, about half of those patients who were, quote, cured actually relapsed without any identified risk behavior. And the more the S antigen declined on treatment or during follow-up, the better the patient, the better the cure rate. So liver transplant for delta is quite interesting, and this is a study that really dates back a long time. There's a Dr. Samuel who was transplanting hepatitis B and B and delta patients. It was New England Journal of Medicine back in 1993. I remember colleagues in the transplant community that I worked with who would go as far as denying liver transplants to any hepatitis B patients, and that's when the HBIG data was emerging, and then HBIG plus lamivudine. And I'm sad to say that some patients just died because people weren't necessarily current with the literature even back 25 years ago. The delta, because it suppresses B and you get a transplant, the chance of having recurrent B or delta is very, very low. And this, of course, is minimized if you use HBIG and one of the nukes for those patients. So once they go to transplant, they have an excellent prognosis, and that should be considered as an option. Now, in the large slide deck that will be posted on the website, there's quite a bit of information from Replicor that was published this last April, and there's an update from Washington, D.C. about a month ago, and there'll be more information at AASLD. This REP therapy, which is a NAP or a polymer that basically blocks release of the virions, small viral particles, SVP, and viral particles, has an impact on delta infection. And this see that the REP, which is the drug up above as monotherapy, had a really multi-log decline in the delta RNA in the serum. Then you added pegylated interferon, a number of patients cleared, and then if you stop a year later, you've got relapse that took place in 5 of those patients. So I think it's better, but I think combination therapy with REP, not just with interferon like was done in this study, but maybe REP, a nuke, and maybe a partnership with other drugs, including the drug that the Eiger is working on, this prenylation inhibitor. I think the cure D is going to take some really creative partnerships. And let's just a little bit more data on building on this slide, but that's available through the website. And then when you normalize or improve liver enzymes, there's something very favorable going on in the liver. So if I have a patient and I knock down their RNA level by 2 to 3 logs and their ALT normalizes, I think that is a very viable endpoint when you're developing a new drug. Of course, you want to cure, but as I said, it might take 3 or 4 drugs in combination. And if you have these reasonable endpoints for your early drug development, then you get more drugs approved, and then once they're approved, you're going to have much easier access to using more advanced combination therapy. All right, let's see if I can get this to go forward. Sometimes the slides stick. This is data from what's called the lower HDV2 study. Cihan Yurdaydin as a researcher from Ankara, Turkey. This is looking at lonafarnib with ritonavir and looking at end of treatment results. Are you actually clearing or suppressing virus?
and this is a multi-center study that took place. This is Serosar. Lonafarnib is a drug that was actually in development for cancer through Merck and has been treated in a lot of different programs. There is some GI toxicity at higher doses, and it's being combined with ritonavir, so you can take the dose from 100 milligrams down to 25 milligrams. And this prenylation is a host target, so the chance of resistance is very, very low. There's over 120 patients who've been dosed. I think that number is actually quite a bit larger, and there's an NIH phase 2 study that was looked at, and this is just a quick peek of patients looking at week 24 of all oral treatment, and then there's a triple treatment with pegylated interferon. On treatment, you're clearing virus in a large number of patients, and I think this is very, very important. And then that 3 out of 5, and it's a small number, says that this drug combination is working for suppressing virus. Cure data is going to be, of course, not just 6 months off treatment, but also following patients out 2 to 3 years to make sure they don't have late relapses of some type. And there's a substantial number of patients that normalize their ALT. It's close to 80%. And that ALT normalization is, I think, going to correlate well with histologic improvement, and that needs to be proven, of course, in some larger phase 3 studies. The phase 2 studies are quite encouraging. I think this just summarizes the information. The bottom line is that at the 25 and 50 milligram regimens, ritonavir boosted the GI side effects, including nausea, diarrhea, and some patients have really decreased appetite, and some weight loss is much, much lower. And those would be some of the choices used for the larger studies moving forward. So we're getting here near my wrap, which is getting close to David Hillyard's entry as he talks about delta testing. But let's just go through a summary. Delta suppresses hepatitis B. That target of suppression molecularly might be the pregenomic RNA that comes off hepatitis B. They're still working out that. But in general, the take-home message is delta RNA levels tend to be in the 1,000 to 40,000 range, and hepatitis B DNA can be undetectable up to 4 to 5 logs. It's pretty unusual to be over 5 logs in any patient. That delta infection can persist even in the absence of active CCC DNA, because I believe there's good data, at least one good publication, that it can be using production of S antigen off integrated HBV DNA. Even if that integrants are truncated in some way, that messenger RNA is making a surface antigen. The RNA virus can attach to that surface antigen, be carried out of the cell, and be infectious. So this is kind of interesting from this Science Translational Medicine that just got published this last week. That looks like in E antigen negative patients or older patients, most of the S antigen that we're seeing is coming off of integrants. So this is really changing a lot of thought processes about hepatitis B and what endpoint should be. LitRep 2139 looks to reduce surface antigen and HDV RNA. That'll be confirmed in larger phase 3 studies, of course. And S antigen clearance, a lot of ways, is the threshold for activation of some type of immunotherapy. And what we want actually is that S antigen to be less than 0.05 IUs, because that's the threshold of the Abbott and Roche assays. Once you're under 1, the chance of getting to 0.05 is very, very high. So I'm using 1 here as a threshold to say you're on a trajectory, but undetectable would be under 0.05. So you can get functional control of hepatitis B and delta infections in patients who are being treated. And it's interesting, let's say you're using interferon for delta infection, but you can also get suppression of hepatitis B from the interferon. So sometimes you can get a double benefit from that. And we expect that we're going to get better control rates. And of course, I've gone through my Cleardex. I gave you the name. I didn't show you any data. I showed you data on lonafarnib. And there's some emerging data on the REP 2139 in combination therapy. And I think super combination is probably the future for our patients. There's a number of other delta therapies that are on here, and I'm just listing those off in this slide as part of the slide deck that's available for your review and download.
So delta infection, important role in the etiology of liver diseases in various parts of the world in surface antigen positive patients. All at-risk patients should get delta testing, and Dr. Hillyard will go into that in a little bit more detail. This is a very serious disease with a high risk of progression to cirrhosis or cancer. You want to screen, you want to either treat those patients with interferon or refer them for clinical trials. There will be a number of delta trials going on, I think, in the US in the next 12 to 24 months, so keep all those patients in your pocket. Vaccine, very important to prevent B transmission and, of course, delta transmission. HDV liver transplant, better outcomes. We talk about SVR rates that are under 20%, in my opinion, with PEG-based therapies, and nukes do not suppress hepatitis delta RNA. Nukes are very good at suppressing hepatitis B DNA and getting that down to 0, but if you've got undetectable DNA, you've got a delta positive patient, you have to be concerned if their ALT is elevated about progression. If you haven't checked delta, DNA is undetectable and the ALT is high, that's an indication to check hepatitis delta antibody. Late relapses, you don't tell somebody they're cured with interferon therapy until they're 3 years out from stopping the interferon, in my opinion. And it's an interesting concept about treating patients longer with interferon, although I'm not impressed that many patients are going to be going for that. So I think that we're at the end of my section, and I would like to hand the baton.
Thank you so much, Dr. Gish. And now we'll turn it over to Dr. David Hillyard to discuss the logistics of HDV testing.
Okay, thank you, Dr. Gish and Sierra. Let me just first check that, yes, I'm able to advance the slides. We'll finish this presentation with a quick overview of the testing and some test issues also. Obviously, unlike Hep B, which is diagnosed by serological methods, it's different for Hep D. It's diagnosed by a combination of serological screening and confirmation of RNA testing. In that sense, it's very familiar, very similar and analogous to the hepatitis C diagnostic algorithm that you're all familiar with. The other wrinkle that's been emphasized in this presentation is that because of the use of the coke protein for packaging, we'll only see hepatitis delta in hepatitis B infected patients. So that should be a criteria for testing. And finally, like the hepatitis C scenario, use of a quantitative test to confirm serologies provides not only a diagnosis, but also a baseline viral load for patient monitoring. And it's our recommendation that confirmatory testing be with a quantitative test. Quant tests are just as sensitive as qual tests these days, and so that's what's to be recommended. You've already heard there are significant differences between hepatitis delta co-infection versus superinfection. Co-infection is generally self-limited, and both IgM, IgG responses as well as hepatitis delta RNA detection are transient. Therefore, previous resolved cases of hepatitis D co-infection are often undetectable. However, when hepatitis delta infects Hep B carriers, the superinfection scenario, there's a strong serological response, and antibody screening assays become an effective means of identifying chronically infected individuals. So there's lots of tests that are available now. There's good tests, as I'll review very, very briefly. But remember, these tests, just like the Hep C scenario, are not 100% analytically specific for infection. Also, because of the biology of hepatitis delta, tests remain positive for variable periods of time in individuals who have cleared the virus. Therefore, positive hepatitis D serological results must always be confirmed using a sensitive HDV RNA test. And finally, has already been pointed out, even after effective treatment in which hepatitis D RNA levels become undetectable, this response may not be sustained and the RNA may become positive again over time in the absence of reinfection. So We haven't performed on the big instruments, as is the case for Hep A, Hep B, and C hepatitis delta, but I want to assure you that we have excellent tests that are available now. And in fact, this is a recent paper, 2016, in which 3 tests were compared to the assay used for research studies for some time at the University of Washington. In this collaborative study, it was shown that 2 available tests, first the immunodiagnostic assay used at ARUP, and also an in-house test developed at Focus Laboratories, compared very, very well to the University of Washington Diasorin research test. In both cases, fine-tuning of cutoff levels led to a complete concordance of positive-negative results among the 3 assays. And so at our institution, Dr. Patricia Slev, who participated in this study and oversees hepatitis antibody testing, is not only very knowledgeable in issues of this, as she is very, very happy to be available for consultation on questions either of the study or delta serologic testing in general. So many hepatitis D RNA tests, qual and quant, have been described in the literature. And a lot of this literature, the results either for the limit of detection or the viral load, have traditionally been expressed in genomic copies. Now recently across the board, and especially for herpes viruses, we've moved to international units. This allows us to compare test to test. It also allows us to compare study to study. And so even though as you read the literature, you may see a lot of literature which are expressed in copies, we're beginning to see this emerge as sort of the standard of testing. This surely will be absolutely the standard of testing going forward. The literature is sparse on what the ratio of the IU to copies is, but based on preliminary studies that we've done here, we think there's probably about 10 RNA genomic copies for each international unit. And then finally, as the slide notes, there is this thing called genotyping, and taxonomic genotyping is absolutely critical for epidemiology, but as Dr. Gish pointed out, it really doesn't have a current role in terms of diagnostic and monitoring paradigms. So, what tests are we performing? The RNA test at ARUP targets 2 regions of the hepatitis delta genome, as illustrated in the black arrows here, and then the probes for these TACMEN tests are shown in blue. What are the advantages of using a double targeting test? Well, for one, and most importantly, it reduces the chance that sequence polymorphisms in the virus, which could create mismatches, might result in false negatives, or in the case of quantitative testing, may lead to inaccurate quantitation. This has been well studied for Hep C and HIV, and this is sort of emerging as an approach going forward. The calibration curve is generated and is shown top right using dilutions of the WHO. There's only so much of that, so what we do at ARUP is we create transcripts to recapitulate the RNA genome. We normalize to the standard. We store these secondary standards in liquid nitrogen to ensure that they're stable, and we give the same result month to month, year to year. So we've had this IU reporting in other areas for some time. And with the adoption of the international standard, which basically consists of a patient plasma sample which has been diluted, aliquoted, and lyophilized, it's worth asking, do we have an accurate sequence for this? If we use it as a standard, is it going to amplify any differently than patient samples? And its initial taxonomic assignment, which was posted on the WHO web page, is shown in green at the top right of the slide here. As part of our assay development, we actually perform both full genome Sanger and full genome next generation sequencing of the WHO standard, and to our surprise discovered that its correct taxonomy was not what had initially appeared. And we published this last year in the citation that you can see. So we certainly hope that knowledge of this correct sequence will help other laboratories in their development and will help this initiative to make tests more comparative to each other. So In summary, I won't go through when to order. These are very conservative recommendations, and I often quote Dr. Gish with the more granular information that is, as he said, when in doubt, test. But the features and benefits of the testing, again, I just will refrain, and that is that using a combined IgM-IgG screening test with confirmation of a very, very sensitive, robust PCR test is the way to go. And this provides the baseline for monitoring, whether it's the natural course of the disease or the course in response to therapy. So the final slide is simply just a direct code that you can use if you wish to order testing. What's listed in the top, the 002 code, is the enzyme immunology for the test that I described. And then below that is our quantitative RT-PCR test. And with that, I will turn things back to Sierra.
Thank you so much, Dr. Hillyard. So now we'll begin the Q&A portion of our webinar. As mentioned at the beginning of the call, we'll start by answering questions submitted to us via the chat box. So we'll just wait a few minutes to let those questions roll in. We can start with our first question. I believe this would be for Dr. Gish. Someone's asking if it has been shown that HDV RNA levels in serum do not correlate with with disease progression, what is the role in measuring the HDV RNA levels in monitoring the HDV progression?
So it's a great question, and I was isolating RNA alone, saying the level doesn't correlate. But if you combine the delta RNA level with the ALT, you have a very good correlate with disease activity and risk of disease progression or active disease progression, real disease progression. So you always want to get a delta RNA quant. You heard from Dr. Hillyard, you don't want to get a qualitative test. Yes, no, you're going to get a number because that's the state of the art globally. And then you're going to combine that with their ALT level, and you're probably going to do more advanced testing. You're probably going to be having elastography in your patients. You may have an APRI or FIB4 in those patients as well. But ALT correlates very well in delta with histologic activity. So in integration of these, not integration of the virus, but integration of your thought process to look at what's happening to that individual.
Great, thank you. And another question for Dr. Gish. Are you expecting rates of HDV to increase with the opioid epidemic? Is this something that is being studied?
That is a fantastic question, and we're going to be at AASLD in 2 weeks, and I'm going to pose that question to the CDC colleagues. They are reporting rates of acute hepatitis B to be increasing alongside C and HIV. I don't know if they're doing Delta testing, so Tonya Hayden and Salim Khalili are my two Delta gurus at the CDC. I'm going to look and ask them if they've got access to those serum specimens to start looking at least serologic levels of responses.
Wonderful, thank you. And a question for Dr. Hillyard. What is the estimated cost of the Delta antibody and RNA testing?
Well, we have lots of different clients with lots of different contracts. I feel a little reticent to throw out a cost. But viral load testing, it falls into the line of other forms of testing. So what you're paying for an antibody test for C or B or any other virus is very much in line. Those costs, of course, are lower than real-time PCR costs, but real-time PCR costs these days have fallen, and providing testing across the spectrum, including hepatitis delta, is often done for a little over $100. There's no special premium for hepatitis delta testing, I think, in any of the laboratories because it's kind of this newcomer.
Thank you. So another question also comes with a comment. A woman says that Her husband is 40 years old and has had hepatitis B for the last 7 years, and he's been treated with Viriad. His liver enzymes are low, and he is currently getting tested for Delta. She's nervous about the uncertainty with there being no current treatments for Delta. And I guess, in conclusion, she's wondering what may be the value of testing for a disease that we don't have many treatments for at this time.
So I think you highlighted in your last sentence many treatments, but we do have interferon. Interferon can cure 15 to 20% of Delta patients. So if I've got a fatal disease and I have something that's got a 20% cure rate, that sounds better than most of the cancer drugs that we're selling for $50,000 to $100,000. So I'm happy with interferon. Not real happy, but I'm happy with interferon as a base. When you treat with interferon and you suppress virus for 1, 2, or 3 years, you might have a late relapse. That patient's also having usually histologic stability or improvement during those 1 to 3 years while you're waiting for new drugs. You want to know if they have Delta because they have a higher risk of progression to cirrhosis or cancer. I want to know for all my patients their risk of progression. It changes my surveillance, it changes education. And if I'm going to check partners for B and the patient's got Delta, I'm going to check their partners for Delta. It's an infectious disease. We want to know if people have an infectious disease, what they have, and what we might want to check people who are contacted. So there's lots of reasons to check for Delta: prognosis, management, being infectious, and we do have current treatment, and there's upcoming clinical trials. All Delta patients should be retained in some type of database with local providers that can then be accessed as we bring clinical trials forward.
Thank you. So another question, are there new clinical tests available in the U.S. that are able to detect these multiple genotypes?
David.
For either of you.
Well, I think that the existing tests are able to, the PCR tests, for instance, and the serological tests do very well detecting the different genotypes. And in fact, my concern in developing the test, as has been the case for other tests, we see within a genotype sequence variation that can confound the test. This is analogous to HIV, where we have B and non-B strains, and many studies done there show that within the B group, that should be the easy to detect group, that there's more variation there. So in terms of molecular, the confirmatory test, it's a good reason to have double targeting. It's a good reason why you need to look at a lot of samples to know and to have the benefit of what is an emerging database of sequence to look at as you do your test designs.
Great. And one last question. Someone's asking, did you say that the HDV antibody testing is the gold standard? If so, can you explain the importance of the antibody test if RNA testing is the baseline for treatment and management?
Well, again, in a screening test, what we're really looking for is a test that has great sensitivity, that is not going to miss immune responses to the pathogen in question. And in the case of this assay, its sensitivity has been shown to be very, very good. But for the reasons I enumerated, and depending on what the pretest probability is, the history of the patient, whether it's a patient who might have been estimated based on associations or where the patient, which country the patient has come from, there will be differences in the confirmation rate by RNA testing. So, the antibody test is excellent because it picks everything up. The RNA test, if it's designed well, and there are many that have been described beyond the ones that I talked to about today, these tests are excellent also because they take into account the different genotypes and are able to pick them all up. I will say it's an important concept that remind clinicians that everything is not perfect. All the way from IBD, HIV testing, Hep C testing, there are occasional sequence variants that are not picked up. But these days, with good databases, these are rare events.
Thank you, Dr. Hillyard. And with that, we'll conclude our Q&A portion of the webinar. Thank you, everyone, for submitting your questions. And if we didn't get to your question today, feel free to reach out to us. via email at connect@hepdconnect.org. And I'll turn it over to Dr. Gish or Dr. Hillyard again for any final remarks.
David, you want to go first with your major conclusions, and I'll hit one or two myself.
No, I think I've stated. The only thing I'll say is that we've been doing testing for a while. The epidemiology that you've so nicely pointed out is very concordant with our results. We're seeing about 40% of our seropositive samples that confirm with the RNA test. And of course, that's highly dependent on how the physicians are picking the patients to send into us. But it's very, very overlapping with your conclusions on epidemiology in the US.
And my take-home message is you have hepatitis B surface antigen positive patients, every person you think Delta, and then you test for Delta if there's anything atypical, risk behavior, advanced fibrosis, ALT is elevated, but HBV DNA is undetectable, have a very low threshold, because testing with confirmation is going to change your management of that patient. And we have new therapies coming. Please, once you find a Delta patient, get those patients into a Delta database, and ARUP through their testing has a database that they have, but we really need to be collecting this data nationally.
Thank you so much. And thank you everyone for participating in today's webinar. And we'll conclude with these last remarks. Please remember to fill out the survey after the webinar. It also includes opportunities for patients and providers to receive more information about these upcoming clinical trials, and also information about free testing for hepatitis D. Also look out for a message from us in about a day, which will include materials from today's webinar. Again, we greatly appreciate your feedback, and thank you all for hopping on today. Thanks so much, and have a great rest of your day.